All right, I think we have critical mass. So we are going to start live streaming and then I will turn it over to the First Lady.
Okay. Thank you everyone for joining. First, I'd want to make sure that I share a disclosure that this meeting is being live streamed and recorded. I wanted to begin by acknowledging the expertise and dedication each of you brings to this critical work. You're here because you understand firsthand the challenges facing our behavioral health workforce and because you have the knowledge and the experience needed to chart a path forward. The governor and I believe deeply that every Oregonian deserves access to affordable health care, including mental health and addiction services. Yet across our state, we face a stark reality. Too many people can't afford the care that they need simply because we don't have enough providers. This crisis hits hardest in our rural communities and among organizations serving low-income clients, where recruitment and retention challenges are most severe. Workers are leaving the field due to inadequate compensation, safety concerns, overwhelming caseloads, and insufficient support systems. Our mission over the next year is both urgent and achievable. Working from the Comprehensive Behavioral Health Talent Assessment commissioned by the Oregon Higher Education Coordinating Commission, we will develop an action plan by January 31st, 2026 that addresses workforce shortages, prevents the loss of experienced professionals, increases workforce diversity and cultural competency. It will improve outcomes for providers serving our most vulnerable populations. Together, we have the opportunity to envision a behavioral health system in Oregon that ensures people can access the care they need the care they deserve when they need it most. As a former social worker with professional experience in the field, I've seen firsthand how the gaps in our system can impact Oregonians in their time of need. I know that we can drive positive change by uplifting the voices of the people on the front lines, bringing together stakeholders and decision makers towards a common goal of ensuring that our solutions work for all Oregonians. If you have questions today as we go, feel free to put your questions on the Zoom feature or raise your hand. You'll see it in the navigation bar. The invitation email you received had Chad Albright's email and phone number, so please call him if you're having tech issues. And lastly, I'm asking if folks will mute themselves when they're not talking just to reduce background noise. So I want to take the next time that we have to do some introductions. I want us to get to know each other a little bit. This is an incredible team of professionals with vast experience in behavioral health across Oregon. I feel privileged to get to do this work with you. I want to introduce my three council vice chairs, Julie Ibrahim, Chief Executive Officer of New Narratives, Eli Kinsley, the Director of Operations at Bridgeway Community Services, and Robin Sansing, the Behavioral Health Initiative Director at Southern Oregon University. Thank you for taking a leadership role on this council. So I would like to have everybody introduce themselves. We mentioned in the agenda breaker question. Know that your bios are going to be shared after the full council meeting. And so we're going to ask that people keep it brief just so we can hear from everybody and keep going. If people can share their name, their current role, the organization the organization where you're located. And then the answer to our quick icebreaker question, which is, if you had a magic wand, what is the one thing you would do right now to improve the behavioral health crisis in Oregon? I'll go first. I'm Amy Kurtek-Wilson. My professional background is as a social worker, and I'm Oregon's First Lady. I live in Salem. I'm a Marvel fan, and so those movies always start with assembling a team of superheroes. And so I feel like if I had a magic wand, I would bring together the people doing the work to develop the solutions to improve the system, just like this council is gonna do, which is why I'm just so excited about this project. So now I'm going to hand it over to Taylor Smiley-Wolf, Deputy Chief of Staff to the Governor, who will call on the vice chairs, and then we'll go to general council members by name for introductions.
Wonderful. Thank you, First Lady. And I will put the prompt in the chat so folks have it as reference. And then we'll start with Robin.
Thanks, Taylor. I appreciate that. I just want to say, First Lady, I'm so excited to be on this Marvel superhero team. I am ready to roll. I'm so excited. So for folks, my name is Robin Sansing. My pronouns are she, her, hers, and I'm at Southern Oregon University. I'm the Behavioral Health Initiative Director and really grateful to be part of this work. Let's see, I think Taylor, I should have looked at the prompt a little better. I think I'm back to the magic wand part, right? Okay, so
Right.
if I had a magic wand, the one thing that I would do right now is in Southern Oregon, we are sorely in need of more clinicians. And one of the things I've been really working on is getting a Master's of Social Work program going here, and also figuring out how do we get more undergrads out into the community doing behavioral health work so they can experience some of this and maybe find their passion. Who knows? But if nothing else, at least get some people educated and so that we lift up the skills of our community. So that's what my magic wand would do. I'll pass it back to Taylor. Thank you so much.
Thank you, Robin. We'll go to Eli next.
Hi, good morning. Eli Kingsley, Director of Operations at Bridgeway Community Health. If I had a magic wand, I think I would wave it all over Indian country and I would help nourish and blossom all of those individuals who just might not think that they can do the work, but really provide them the confidence and just kind of the internal capacity to recognize that they are probably already doing the work and that they can do the work. They just probably need a little guidance and really just kind of bring more representation into the field of people of color would be my magic wand. Thank you.
Thank you, Eli. Julie.
Good morning, everyone. First Lady, thank you so much for this opportunity. I really consider it an honor, and I am excited to start working on this really, really important issue. I'm Julie Ibrahim. I am the CEO for New Narrative. We're a nonprofit mental health agency. I'm also an LPC. If I could wave a magic wand, I would pay our clinicians, our peer support specialists, our frontline workers, a whole bunch more money, like 20, 30% more, because their work is hard and they deserve it.
Thank you, Julie. Next, I know Monica Vine has to jump off to teach in a few moments. So Monica, will go to you and then to your delegate after you head out, Sean.
Thank you. Monica Vines. I'm at Central Oregon Community College. I'm the program director for the Addiction Counseling Behavioral Health program here in Bend, Oregon. And I guess my magic wand would be similar to Julie's in that paying folks a living wage would make them more invested in both entering the workforce and staying in the workforce. Thank you.
And I'm Sean Roberts. I'm with Monica here. We're kind of tag teaming between summer contracts and teaching, and she's going off to teach here shortly. Our students are downstairs. I just finished. And I'm also a counselor, run a counseling clinic here in Central Oregon. Um, I think a different magic wand behind all the wonderful ones you all waved would be just creating more pathways for practicum and internship, more support for organizations so that it feels like it's worthwhile, and more wraparound development for these new professionals who don't have the support to navigate it, burnout. So that'd be something I would love to see.
Thank you, Sean. Ebony, do you want to go next?
Good morning, everyone, and First Lady. Just honored to be a part of this. You know that I'm committed and about action. My name is Ebony Clark. I'm the Behavioral Health Director for OHA, pronouns she, hers. Oh gosh, I only can do one. So, okay. So if I had a magic wand, I would bring increased parity between the compensation and pay between those that work in hospitals, CCOs, counties, providers in the state, just so that then folks really can, do the work and be in the realm and not have to always think about, they got to take the job that's going to allow them to pay their bills. So just more reciprocity across pay, regardless of the setting. And if you are working in a more acute setting, you do get paid a little bit more.
Thank you so much, Ebony. Julia.
Good morning, Julia Pontoni, Director of the Office of Workforce Investments at the Higher Education Coordinating Commission. I use she, her pronouns. My magic wand would create paid work experience opportunities for all behavioral health students.
Thank you. Todd.
Good morning, everyone. Excited for this opportunity. My name is Todd Youngkin. I'm the Executive Director for the Mental Health Regulatory Agency. Quickly, for those who don't know, we provide support to and oversee the Oregon Boards of Psychology and licensed professional counselors and therapists. If I had a magic wand, I mean, there are so many. I think one of the things I'm looking for that this committee can actually do with their magic wand is help grow the shared understanding of the dynamics across all that. We have a lot of varied folks and daily, we're most familiar with what we know, our own limitations, our challenges, our capabilities. I'd like to see that understanding grow across the group. Thank you.
Thank you so much. Van.
Hey guys, I'm Van Burnham. I'm the executive director of MacBo. I'm thrilled to be here. As far as the magic wand, I'd like to see funding for a position at licensing and certification boards to have a career ladder consultant. So like a staff that would answer the phone and sort of assess where people are, help them navigate barriers, around their particular situation, and then point them towards like scholarships, employment opportunities, colleges that have programs that pertain to them. So, I mean, it's a daily phone call that we receive at MacBo, and I know all the licensing boards get the same phone call, where people call and they just, they don't know how to start the process. And, if it's too daunting, then people never enter the field. So just a way to help people navigate barriers, would be my magic wand.
Thank you, Van. Rachel.
Good morning, everyone. Honored to be here, and thank you, First Lady, for bringing us together because there's a lot of people in this room that I've wanted to work with, and I get the opportunity. So, Rachel Prusak, Executive Director of Oregon State Board of Nursing, so currently in the Executive Branch Regulatory Board with Todd, but I'm going to put the magic wand in my clinician hand and why I ran for office, what I fought for to ensure we kept people in the workforce is how can we take the wand and remove the red tape and the administrative burden that burns people out, and potentially, therefore, we have increased access in all of our settings. And thank you all for using your wands for some of the other things that I would do. So I got to elevate that one. Glad to be here.
Thank you. Next, we'll go to Mary Peterson.
This really is the A team. I am honored to be part of it. Wow, this is great. So I'm Mary Peterson. I live in Portland. I'm the provost at George Fox. I'm a psychologist by training. Worked with YCCO for years and years. Eli took my first choice, which is a diverse workforce. I've applied for multiple grants over the last 20 years, some successful, some not. So diversity. The other thing, though, is integrating wraparound services rather than just putting the burden on a one-time clinician. How are we making sure that we're integrating services to wrap around and layer in all the things that Oregon offers to support healthy living?
Thank you. Rick.
Hi, and thank you, First Lady, for putting this together. It's a desperate issue that we face every day. So my name is Rick Trelevin. I'm LCSW, and I'm the CEO of Best Care Treatment Services, which is a behavioral health agency, SED mental health agency in Central Oregon. So lovely magic wands. Really appreciate it. So I support all of those magic wands. So I'm really going for magic thinking here. It was 40 years ago this year that I started graduate school, and I was outraged that I had to pay $6,000 a year in out-of-state tuition for my MSW program at the University of Washington. I ran that through inflation calculator yesterday. That's $18,000 a year. And that's just a completely different experience than people entering the field now. I have no idea why they get into the field anymore. It's completely makes no sense. So I have a workforce that we recruit because they're not working on their own reasonable self-interest. So reverse the last 40 years of double-digit higher inflation, higher ed inflation. But I think that's one of the core problems. And so our staff come here with grinding debt. And of course, housing prices have skyrocketed Central Oregon. So they have grinding debt, and the chance of having a middle class lifestyle, owning your own home, that's just off the table. Yeah, that'd be it.
Thank you. Clarissa.
Thank you so much. My name is Clarissa Carson. I am a psychiatric mental health nurse practitioner down here in Medford at an FQHC named Road Community Health. Thank you so much, First Lady, for including me. My goodness, all these smart people. I'm just so honored. And as a nurse practitioner working in psychiatry, I think if I had a magic wand, I would cut every provider's panel down by a third. I would get them a scribe or whatever AI options we have now. And I would give them a mental health day per month to use for their health and wellness, just that rest, relief, and all the reasons to stay in this work that we love. Plus all of the amazing things you guys said. I think that all of those apply also to us psychiatric mental health nurse practitioners. So thank you so much.
Thank you. Alice.
Hi, everyone. I want to echo what others have said. It's so wonderful to be in this room, and thank you, First Lady, for the invitation. I am a faculty member at the School of Public Health, which is a joint program with OHSU and PSU, so I'm located in Portland. But I was hired to do public health workforce development in rural Oregon, so I'm going to be working across the state, at least for the next 3 years. And my magic wand, building on what others have said, I've been in higher education. I'm a social worker by training, and I've been in higher ed for about 20 years. And so I think a lot about enrollment and, as others have mentioned, pathways. So I was thinking about a magic wand that would create an alternate universe where people are so persuaded about the value of having a healthy, strong behavioral healthcare system that's integrated with all the elements we know, that starting in, and this is drawing on the needs assessment, 6th grade, people are starting to talk about dreaming about the kinds of careers they want to have in behavioral health. So, bing.
Thank you. Jamie.
Hey, thank you so much for having me. I'm Jamie Vandergon. I'm the CEO of Trillium Family Services, which is a statewide provider of kids and families mental health care. We're the only provider of the full spectrum of care from mental health promotion all the way to the state hospital for youth, which we run on our Portland and Corvallis campuses. And my magic wand would hopefully reverse the system that we currently have, where our most experienced clinicians are working with our sort of lightest population. So we would have that most experienced group working with the most acute and most complex cases, which, like I said, would be almost a complete reversal from where it is now. That's going to obviously tap into the wages, the administrative burden, and burnout. And why we all move away from those highest levels of care where we need the most experience. And yeah, I'm an LPC. I still have an LPC by training. So
Thank you. We'll go to Janie.
Good morning, everyone. Thank you, First Lady, for the opportunity. And I'm so excited to be in this group and work with co-conspirators for change. I'm thrilled. My name is Janie Gullickson. I use she, her, hers pronouns. I'm a woman in long-term recovery from both mental health and addiction challenges and all the intersecting life experiences that can come with that. And that recovery has afforded me some certifications that I'm proud of: peer support specialist, certified recovery mentor 2, and a grad degree in public admin health administration. It also has afforded me to be, over the last 10 years, working at the peer-run organization, the Mental Health and Addiction Association of Oregon, as the executive director. And we are soon to be the peer company, so transitioning to our rebranded name. If I had a magic wand, I think what I'd like to see is ditto to what has been shared, and to add to that, instead of having an illness-based healthcare system, we have a recovery-based healthcare system. Let's bring back the most amazing parts of the moral treatment movement and give people time and space to heal. And that means the workforce is healers, not illness managers. And I think that would uplift and give hope to the workforce as well. Thank you.
Thank you so much. Julia.
Thank you, First Lady, for inviting me to this panel. It's a wonderful experience. So I'm going to say that we're in need of a more diverse workforce, and the fact that folks that are helpers need to be paid as folks that are helpers. Like, we need wages that mirror inflation and sustainability. It's hard to get, and then more training, especially for the entry level folks, because I and Van both sit on an ethics board, and there's so many ethics things that come across us that is just, there needs to be a lot more training of folks that if you're a helper, these are the do's and don'ts and how you truly help and not harm.
Thank you. Next, we'll go to Shira.
Hi, I'm Shira Marilla Simmons. I'm the executive director at Clatsop Behavioral Healthcare in Clatsop County out here at the coast. Also really honored to be here. I have had to change my magic wand answer like 3 times now because you've all stolen mine. So what I will contribute, if I had a magic wand, I would build out the continuum of care for all recovery services. So when folks needed to access care, they could access it now and they would be met where they're at. I think that a big contributor to burnout in our field is providers feeling like they're not able to make an impact or make a difference because they don't have access to the resources that they need to truly help people. I think that means that clients end up feeling hopeless and providers end up feeling helpless. And as we know, you don't get into this work for the money. So if you're feeling ineffectual, I think that, chances are high you may choose to do something else. So thank you.
Thank you. Summer.
Hi, everyone. I'm Summer Walcott. I'm the executive director at OnTrack Rose Valley. We have services in Josephine and Jackson County, and I'm technically an LPC by training, though I haven't actually been a therapist for a really long time. My magic wand is going to just have to add power to the other wands that have all spoken on behalf of funding. Because to me, sustainable, predictable funding is the root of so many of our issues in behavioral health and the workforce crisis. We have sustainable funding that's predictable. We can offer competitive pay. We could hire enough staff to reduce the caseloads. We could build more capacity so that people were getting the right level of care. And it would just, there's so many different things that would be impacted. So sustainable, predictable funding for competitive salaries and being able to build out the system.
Thank you so much. Next, we have Bethany.
Hello, I'm Bethany Wallace. I'm a licensed clinical social worker and associate professor of practice and practicum specialist at Portland State University's School of Social Work. And I know a few of you in our time together. I live in Salem and am primarily responsible for finding and developing practicum opportunities for bachelor's and master's level social workers in the Salem and surrounding areas, and then support our full team in statewide practicum development. And my magic wand would be to fund practicum initiatives and development. And for me, what that would look like is paid internships or stipends for students, as it is not what it once used to be. And many of our students can't eat sometimes, can't pay the rent. They're deciding between different things, and they're working full time. And so it's just not how it used to be when we were students. And so finding ways to um, fund them, to train those that are practicum supervisors so that they have the adequate training, but also incentivize and pay them for the really important work that they are doing, as well as the programs that are supporting students so that they have the right amount of staff to support the agencies as well as develop the placements. So really just a really robust funding so that they we have really good relationships and supports, because I think that will help all these other areas in kind of a healthy cycle.
Thank you. Tammy.
Hi, everyone. My name is Tammy Paul. I use she, her pronouns, and I serve as the Executive Director for Oregon Family Support Network. We're a statewide organization supporting families raising kids with behavioral health challenges. So my magic wand would be a certified family support specialist for every family at the first inclination of any challenge that a child has. So we meet needs before we get to the adult system and behavioral health needs. Thank you.
Thank you. And Liz. Liz, you're still muted. If you're talking, we can't hear you.
Sorry, I'm having some technical difficulties today. It kicked me off for a second, but I am Liz O'Connor, she, her pronouns, and I work as the triage clinician for Project Respond, which is the Multnomah County Mental Health Mobile Crisis Team. And I also am one of the lead stewards for our union. And if I had a magic wand, I would both unionize every mental health agency, because I am definitely very pro-union, and also just fully staffed so that we are not ever at capacity and we can meet the needs of the community. So many times we're the end of the road at Project Respond, where all the other systems have kind of failed, and more often than not, it's just that there's no staff to be had and no clinicians to be assigned to people, and or peers or any of that. So that would be my magic wand, and I really appreciate being here and this opportunity.
Thank you. First Lady, I will turn it back to you.
This is an incredible group of people. I have to stop and just say thank you to everyone. It's just so exciting. And the reason I chose a magic wand question is that this work is hard. We spend a lot of time talking about how hard it is and all of the barriers, but what we want is tied to what we can imagine. And so I just want to thank you for dreaming with me and thinking about what could be. We got through, everybody was so brief and short and on topic that we have extra time. And so if it's okay, we thought we might roll into the HEC presentation. Okay, good. So we're going to kind of skip over the break for now, and then we can maybe take that after the presentation, and people can kind of get some water, make phone calls, do text, whatever they need to do. I'm going to turn it over to our partners, so it's the Higher Education Coordinating Commission, henceforth known as the HEC, to present the findings from the behavioral health talent assessment that is going to serve as the foundation of the council's work. So this comprehensive report was produced by Advocates for Human Potential in collaboration with HEC. And so know that there was a diverse steering committee of behavioral health experts. They did a detailed analysis of Oregon's behavioral workforce pipeline. They did extensive research, they did stakeholder interviews, and then they did surveys with professionals in the field. And then this report will kind of guide our work. I will tell you also, I watched the presentation when I would, and I was like, oh, report, how could they possibly? And I watched the presentation, I was amazed. And then I read the report and it was thrilling. Thrilling. I don't talk about thrilling very often with reports, but it had all the things in it. It had more, and if it didn't have it incomplete, it at least started it. It called out the workforce shortages. It called out pathways. It called out the different types of workers we needed. It just really, and it provided this incredible framework. So I want to just thank them for their great work. This will be our guide rope for the work that we're going to do, because we got a lot to do, but the way that we're going to get it done is we're going to follow the recommendations in this report. We can add to it, but part of this is prioritizing moving forward. So I want you to know that Sarah Foster, in the governor's office, she does workforce, labor, and higher education. And Shaylee Hogston with HEC are both on standby to answer questions. And then I am going to pass it over to Jennifer Purcell. She's the director of Future Ready Oregon at HEC, and she's going to walk us through the talent assessment. And if we could just hold our questions to the end of the presentation, or you could put them in the Q&A and then we can moderate those at the end. And so thank you so much. Take it away, Team HEC.
Thank you so much, First Lady. Thrilled to be with you and the members of the council. Appreciate the opportunity to be with you today. As was mentioned, my name is Jennifer Purcell. I'm the director for Future Ready Oregon at the Higher Education Coordinating Commission, and I'm joined today by Shali Hodgson, who is with HEC's Office of Community Colleges and Workforce Development. We're thrilled to be supporting the work of this council. I am here this morning to share a summary of the recent behavioral health talent assessment, and I understand you all have had some time to dig into it. And I think that Sarah is driving for me, so we can go to the next slide. Thank you. So first, for those of you who may not be familiar with the Higher Education Coordinating Commission, or the HEC, I wanted to provide a little bit of an intro and context. So the HEC is responsible for developing the state's goals and strategic plan for post-secondary education and training through a wide range of policy and funding strategies, including grants and scholarships, as well as training resources to support students and learners. The HEC administers the statewide higher education and workforce biennial budget of approximately $4.1 billion. And it establishes methodologies for distributing public funding to community colleges, universities, directly to students, local workforce development boards, and other partners, coordinating post-secondary degrees, programs, and academic pathways, administering statewide financial aid, workforce, and educational programs, and providing research, evaluation, and analysis. Next slide, please. The Oregon Behavioral Health Talent Assessment and the corresponding career pathways map, as the First Lady mentioned, were developed for the HEC by Advocates for Human Potential, or AHP, with the intention of informing program options that prioritize critical shortage occupations and emphasize growing and diversifying the supply and distribution of the behavioral health workforce. This 2025 report identifies pathways for Oregonians to behavioral health careers and evaluates barriers and opportunities for recruiting, training, and retaining a diverse behavioral health workforce. The assessment also projects future workforce demand, as well as the demand for education and training programs across Oregon. AHP's work to prepare the report centered on two fundamental research questions. How can Oregon improve the return on investment in the behavioral health field for employers, practitioners, and the folks that are being served in communities? And how can Oregon best offer a range of opportunities, access, and supports for folks who are pursuing a career in behavioral health? Next slide, please. So AHP's assessment began with a review and summary of the existing behavioral health workforce supply and demand reports and analyses to ensure that this talent assessment addressed gaps and built upon existing work. In collaboration with the HEC and an engaged steering committee, excuse me, AHP set out to provide a characterization of Oregon's behavioral health talent pipeline, disaggregated by race, ethnicity, gender, age, geography, educational attainment, and employment. And this work involved a series of focus groups, key informant interviews, and a survey of behavioral health professionals across Oregon. The talent assessment itself includes a comprehensive overview of the skills landscape within Oregon's behavioral health industry, an illustration of the pathways through which qualified students enter and exit the behavioral health workforce, an inventory of post-secondary education and training offerings, including workforce service providers, training organizations, community colleges, and public and private universities. And it provides a foundation for identifying effective programs and potential partnerships between educators, community-based organizations, and employers. Findings and recommendations include a broad programming gap assessment that details what is available in Oregon, where expansion is likely needed, and where current levels of programming are sufficient. Note that this project was meant to provide a baseline for Oregon in terms of addressing the challenges outlined in the report. It's intended that there will need to be a deeper dive into many of the findings. Next slide, please. AHP's work integrates workforce supply and demand data. Their analysis considered current behavioral health workforce and talent demand, identifying where there are shortages and assessing projected demand to identify gaps in the supply and distribution of the behavioral health workforce in Oregon. And AHP identified high-value credentials and pathways into the behavioral health field, assessing recent post-secondary enrollment and graduation data. Lastly, AHP developed predictive analytics to really highlight and explore the challenges that are faced along the academic pathways and into employment in the behavioral health sector. Next slide. We want to share a quick overview of the demographic makeup of the behavioral health workforce in Oregon. So this will ground you in the current state. On pages 13 through 15 of your report, AHP provided charts and graphics that visually represent Oregon's current behavioral health workforce by race, ethnicity, age, and gender. This data comes from the Oregon Health Authority's What's the Health Workforce Supply in Oregon report from April of 2023. The first chart breaks down Oregon's current behavioral health workforce by race and ethnicity. I want to draw your attention to a few significant findings. First, clinical social work associates have the highest percentages of Latino, Latina, Latinx, Black, African American, and American Indian or Alaska Native individuals among all of the behavioral health occupations. In contrast, clinical nurse specialists have the highest percentage of white individuals. And while Latino, Latina, Latinx people make up nearly 15% of the state's population, they are vastly underrepresented in the behavioral health workforce across all occupations. Next slide, please. This next chart breaks down Oregon's current behavioral health workforce by age. Significant findings include that Clinical social work associates have the highest percentage of individuals under 35 years old. And physicians and physician assistants have the highest percentage of individuals ages 35 to 54. And clinical nurse specialists have the lowest percentage, less than 0%, of individuals from under 35 years old. And next slide, please. Lastly, this chart breaks down Oregon's current behavioral health workforce by gender. Significantly, women are generally overrepresented across behavioral health occupations, while men have a higher representation in physician roles and other high-paying roles compared to women. Next slide, please. Understanding the current workforce composition is just one step in understanding supply. AHP also researched education and training pathways into the behavioral health workforce, including recent enrollment and graduation data and changes in enrollment before and after the COVID pandemic. Tables 8 through 10 on pages 36 through 38 of your report present data regarding behavioral health course enrollment, behavioral health associated majors, and credential or degree attainment. These were provided by the HEC for the 17 community colleges and 7 public universities in Oregon. And as you can see here, the number of community college students whose first declared major is behavioral health and who took at least one behavioral health course decreased by 57% between 2014-15 academic year and 2018-19 academic year. It then increased by 56% post-pandemic. However, the overall trend for community college students, including the pandemic years, still shows a decrease of 35%. This trend was different for public university students, which generally increased over the same time period. You can see a 22% increase in public university students whose first declared major is behavioral health and who were enrolled in at least one behavioral health course. Similarly, results show decreases in the number of students who earned a behavioral health credential from community colleges and slight increases from public universities. While these data show an increase in the overall number of students enrolled in behavioral health majors and earning behavioral health credentials, the trends reveal a decline in students entering the behavioral health field from community colleges over time, which is a trend that started prior to the pandemic. Next slide, please. The AHP report integrates projected supply and demand data, considering the current number of workers active in the workforce, which consists of people working and people actively seeking employment. And they estimated increases and decreases in the workforce over time, as well as projecting demand and increases for demand for behavioral health services over the next 10 years. As you can see in this table, which is on page 24 of your report, over half of the positions listed project a shortage, some quite significant. For example, child, family, and school social workers and adult psychiatrists will be understaffed by almost half. Mental health counselors and occupational therapy assistants by nearly a third, and addiction counselors by about a quarter. With supply anticipated to fall considerably short of demand, retention becomes essential. Next slide, please. So now that we've taken a look at the workforce supply and demand landscape, let's dive into AHP's findings and recommendations. AHP heard from educators and folks working in the field that there are several challenges exacerbating Oregon's ability to meet its behavioral health workforce needs. AHP emphasized that Oregon must address wages for the behavioral health workforce for any of the strategies to truly be successful. Wages are a key piece of a complex puzzle that Oregon must solve to meet demand. These pieces inform the report's primary findings and recommendations. And the first piece to keep in mind is the high cost of education, which is not just a challenge in Oregon, but all over the country. And in the behavioral health field, this can be particularly challenging when comparing the cost of education to the pay potential for working in the field. Another piece of the puzzle that is impacting Oregon's ability to expand and diversify the behavioral health workforce is a lack of supervisors to help folks enter into and thrive in the field. Research participants indicated there are not enough senior staff to provide the quality on-the-job training or supervision needed for advancement. And this is driven in part by a lack of competitive wages, particularly compared to other healthcare career pathways. And this is compounded when folks are leaving the behavioral health field for other positions as a result of burnout, workplace dynamics, and limited advancement opportunities. Retention is also impacted by an increasing shift to private practice. People are leaving after a few years to earn higher pay, work with fewer acute clients, and fewer clients in general. And these pieces are all informed by the structural, social, and systemic challenges that Oregon and other states are feeling very acutely, including conflicts with regulations or prescriptive care mandates, high administrative burdens, and an increase in the cost of living. So it's a multifaceted puzzle of interrelated challenges. Next slide, please. I'd like to share a few highlights from AHP's survey of the behavioral health professionals. It's important to note that nearly 3 to 4% of the entire behavioral health workforce in the state of Oregon were surveyed as part of AHP's quantitative analysis. AHP indicated that this level of participation is really quite rare, and it allowed them to increase their confidence in the statistical generalities of their findings. One of the bright spots in AHP's findings was the effective, affordable pathways to behavioral health positions from Oregon's community colleges to bachelor's programs and into the workforce. However, compared to national trends, the average completion rates for bachelor's and community college programs were below national averages for the last couple of years. And in 2023, they were almost half. That by itself could be a significant part of the issue in terms of the limited talent pool. And regardless of other recommendations and approaches, AHP's findings indicate that if that doesn't show an improvement, it's going to be challenging to move the needle on the shortages. Additionally, AHP's research confirmed that burnout and retention are prevalent in Oregon's behavioral health workforce. One of the first pieces they found that was surprising was that a significant amount of folks were intending to quit their job in the next 30 days. The findings varied by age, with 61% of 30 to 39-year-olds indicating they intend to leave their job in the next month, followed by 18 to 29-year-olds at 44%. AHP emphasized that a big part of why folks like their jobs, why they're in the behavioral health field in the first place, is values-based. They have a desire to help people. However, AHP indicated that burnout rates are abnormally high compared to other parts of the country, both in terms of the average overall for those intending to quit, as well as within each of the age groups. AHP also evaluated how experiences along the education continuum predict whether someone will actually become a behavioral health professional in Oregon, and how likely they are at this point in their career to leave the industry or quit their job. AHP found that having a family member or close family friend significantly that was in the behavioral health field significantly increased the likelihood that an individual would enter the behavioral health workforce themselves, 12 times more likely, in fact. Additionally, AHP's data suggests that folks who wait to choose their major until later in their college career were more likely to choose behavioral health. It is possible that behavioral health is being chosen because students didn't get into other programs of choice. It may be a choice of last resort. It may also be that they discovered the opportunity later in their educational journey. But AHP's analysis further indicated that these same individuals are much more likely to be ready to quit the profession. In fact, individuals who waited until year 5 or later to choose their bachelor's major were 15 times more likely, on average, with all other variables considered, to indicate their intent to leave the behavioral health workforce. Next slide, please. AHP identified at least 4 interrelated leaks in the behavioral health talent pipeline, starting all the way from K-12 through community college, bachelor's programs, and graduate programs. Although once folks got to the graduate program level, there was a significantly less evidence that there was a leak. There was evidence that turnover and retention issues are rampant in behavioral health. And of course, that's not unique to Oregon. That has been increasing across the country. And there's some sense that the awareness of this dynamic is also increasing, which is influencing how people are thinking about their career choice. This likely affects the pipeline starting from the very beginning. And that could be, for example, why it is so disproportionate that the odds of you being in the behavioral health workforce are so much higher if you have a parent or a family friend that's already in the field. That is, unless an individual is predisposed or provided a differential framing of what it looks like to be in the behavioral health field, they're less likely to consider a career in behavioral health. Now, when you couple that with the fact that folks aren't graduating from community colleges and bachelor's institutions at the same rates as non-behavioral health majors, and then you consider that students are waiting longer to declare their major in behavioral health, AHP identifies these as leaks in the pipeline that are all contributing to Oregon's behavioral health workforce crisis. And when I say crisis, AHP's findings indicate that 32 of Oregon's 36 counties lack even one provider per 1,000 residents. Next slide, please. Lastly, licensure and training barriers came up in nearly every interview and focus group. Here you're looking at a snapshot of a map of behavioral health career pathways in Oregon that was prepared by AHP. AHP started by identifying 60 different behavioral health credentials and licenses offered by 14 distinct certifying and licensing boards in Oregon. They used available scopes of practice and identified key skills standards across the 60 credentials and licenses. The careers are mapped based on their educational requirements. So starting on the left, you'll see a minimum degree needed for the role. Next to that is the certifying or licensing body responsible, followed by the credential that they offer. And finally, the occupation that that credential is tied to. This layout helps clarify how education and credentials connect to specific roles. And this snapshot features just a small portion of the pathways AHP developed. And the comprehensive behavioral health career pathways map accompanies the behavioral health talent assessment. It's worth noting that when AHP analyzed both career pathways and skill assessments, they discovered that essentially all of the jobs in the progression share similar key skills. However, there are regulations defining who is legally able to provide certain services that limit flexibility within the occupations. So as folks progress into these roles, there are supervised experience hours required at each level that, once met, grant the individual the ability to perform certain services. Throughout the mapping process, AHP discovered that finding this information and mapping it was extremely challenging and confusing, which may present a barrier in and of itself for folks looking to enter the field and trying to figure out where they might best fit in the spectrum of options. They also discovered that some pathways offer very limited upward mobility, and progression may require additional education or supervised hours that can result in increased costs for the individuals. And as I mentioned earlier, higher education may not always yield a positive return on investment. In some cases, there's very minimal opportunity for pay increases within the occupations that make it challenging to convince someone to continue to meet those additional requirements. This career and credential pathways map illustrates the complexity of the behavioral health workforce system in Oregon as an additional barrier to growing and diversifying the workforce. Next slide, please. So, go to the next slide and then we'll come back to this one. Slide change in order. Thank you. So what do we do with all of this information? Staff at the HEC and OHA, along with the governor's behavioral health initiative team, have been combing through these findings and recommendations to identify promising next steps and strategies to address Oregon's behavioral health crisis, workforce crisis. AHP's recommendations include increasing access and financial support for education, particularly with an equity lens, and considering supports for rural and frontier students, as well as culturally and linguistically diverse groups. AHP recommends expanding collaboration with employers to create a more streamlined career pathway and support structure for folks who are entering into the field. And in terms of retention and advancement opportunities, AHP recommends developing clearly defined career pathways that are supported for advancement potential. Additionally, AHP recommended further investigation into discrepancies between those completing education inside of Oregon and outside of the state, looking at how behavioral health majors are chosen and better understanding what's driving burnout and turnover. Back to the other slide, please. So as you can see, there are a number of interrelated and complex challenges that are impacting Oregon's behavioral health workforce. A suite of solutions will have to be considered to ensure Oregon is producing a sufficient supply and distribution of behavioral health workers to meet service demand. This slide illustrates how the HEC is thinking about the learner and worker journey and the interconnected nature of the ecosystem. This framework is designed to illustrate how HEC and OHA activities impact the entire pathway throughout education and career. It emphasizes that strategies and solutions must consider workforce development, education, and health policy. It will be essential to consider recruitment, retention, and advancement in both education and in career. This council will consider the interconnected journey and experience of workers and learners and will be embarking on next steps to advance the findings and recommendations. And the council subcommittees will consider licensure and credentialing, provider recruitment and retention, and education and training pathways, prioritizing the recommendations and identifying the strategic policy levers and points of influence along the interconnected education and career pathway. And with that, if you jump forward to the final slide, I'm happy to take questions. Thank you so much.
I've got a question about the licensing and training complexity slide. If there's any way you can go back to that. So this slide, these are our credentials. These are MacBo's credentials. And I think this really sort of hammers on the point that I was making in my magic wand statement, is that when people call, we're trying to assess where they are, and maybe they have a criminal history, and maybe they live in Eastern Oregon, maybe they have some work experience or some education. And we have to figure out, where to put them in this map and show them what is the best possible path forward, the path with least resistance, with the most upside as far as a trajectory goes. And it's hard, and all the licensing boards and credentialing boards have this same challenge. When people call and they want to be an alcohol and drug counselor or a mental health counselor, if you don't paint a realistic picture, in that phone call, then oftentimes they go and they apply for a job elsewhere in a different field. So I think it's a really important slide. And And I mean, you're right. It's actually more complex than this slide, because the CRM class could work for the QMHAR non-degree path, and so could some of the work experience. And we work so hard to create, our website as easy to understand as possible. But if you don't work in this field, it's so hard to interpret. So I mean, I really appreciate this slide, and just hammering that in. So thank you so much. That was a wonderful presentation.
Thank you, Van. I did note that many of your magic wand wishes aligned with items that were discussed in the report. So thank you for that.
All right, and we have some hands up, so go to Clarissa next.
Thank you. I was just curious how many psychiatrists or psychiatric mental health nurse practitioners were included in your report. It seemed a little more shifted towards the therapy and social work side of things. Even when I was looking through some of your appendices with the skills assessments and the licensures, I was just wondering if there was a lot of input from the medical side of things, since I know we're just part of the team, but we are part of the team.
Thanks so much for the question. I think you're asking specifically about the behavioral health, the survey of behavioral health professionals, as well as the key informant interview and likely the focus groups. I don't have right at my fingertips the makeup of those, but my understanding was that that primary research was designed to supplement the data that was readily available through secondary research. So there's a complement, but I'm happy to follow up with more information about the methodology.
Thank you. Rachel.
Thanks, Taylor, and thanks, Jennifer, for the presentation. So just a brief comment, because I know it was elevated as an outlier, so I want to give some context to it, given I'm here representing the Board of Nursing and nurse practitioners and clinicians. But so it's mentioned that there's no CNSs, under 35, the average age is 57. But what I want to share for context, so we don't go looking for something, is we don't have any programs on the West Coast to engage in that anymore. We have much more people getting their nurse practitioner, APRN. So I'm a family nurse practitioner, Clarissa's a psych NP. And so now that's where the workforce is. We have 9,406 nurse practitioners and more all of the time, because the CNS program is an older program. We don't have any. Currently, right now, there's only 121 licensed. And so I don't think it's necessarily a bad thing that people aren't going to that anymore. It's that they've transitioned to the psych NP or the FNP that can care for those in the behavioral health workforce. So just wanted to provide some context so we don't go looking for that outlier or something to fix. Thank you.
Thank you for the context.
Jeannie.
Mute button and a weird pop-up in front of it. Thank you for that presentation. Yeah, that was fascinating and helped really synthesize the bigger document. Amazing work. I'm wondering about the private practice versus public and nonprofit career, the data related to that, or was that considered?
Thanks for the question, Janie. Is it related to the folks that were interviewed, again, from the survey or key informant interviews, focus groups? Is that the question? I just want to make sure I'm answering the right thing.
Yeah, sorry, it wasn't very clear with that. And I was reflecting on my early grad school experience where I was following that track of becoming a professional mental health and addiction counselor before I went into public administration. And what I saw in my cohort was many were planning on just going right into private practice after internships or practicums. So I'm just wondering if in these numbers, let's say for the rate of mental health providers per 1,000 residents, is that in the public system or just overall?
That number in particular is overall, and I think there's some important distinctions in the surveying. Again, really tried to be thoughtful about who we included in the key informant interviews and the focus groups to ensure that we were really as broad as we could be in the perspectives that were contributing to those findings. The survey of behavioral health professionals was broad. I don't have a breakdown at my fingertips of that, but we can follow up with you. And we wouldn't know, I don't think we would know in the behavioral health enrollment and graduation data whether folks are pursuing public or private practice, but certainly something for this group to think about.
Excellent. Ebony.
The slide that had the breakdown by race of the kind of the different categories. And then I think there was the category that was, I don't know if it was non-social work. Is there a breakdown of QMHAs and QMHPs by race?
It's a great question, Ebony. That data comes from OHA's workforce supply report from 2023. I believe, I'm going to flip to the page, but I believe that there was insufficient data for the QMHA, QMHP, and that series in 2022. I think OHA is updating that workforce supply study, and it should be released imminently. And I'm not sure whether the 2024 data will include that series, but we'll follow up.
Oh, can I just also add that the reason why I also ask is, wanting to kind of compare, wondering if, we find that it's difficult or challenging for, Black African Americans to pass a licensure exam, then I would assume that we would see higher rates of African Americans, as an example, in some of those categories. And so just want to give a little bit of context to my question. So thank you.
You bet.
Thank you, Liz.
I was wondering, I don't know if there's any way to qualify this data or if there's any way to collect it. I know there used to be programs where people could be like grandfathered in to different things. I know there's like people that work at Project Respond that way back in the day, they were able to like be grandfathered into programs like essentially equitable to QMHPs and being able to become hold certified and things like that. Is there any way to gather data on like the impact of those programs going away and how that impacts the ability to like people to advance in the field, for there to be like no more like non-degree ways?
I'm not sure if that question was for me or to prompt discussion.
More just like, yeah, in general, I just wondered if there was any way that when the data was collected, if there was any way to indicate like if people were grandfathered into those programs and if there has been any like any data collected around the impacts of that.
Not that I am aware of in this particular study, but I will follow up to confirm.
Thank you.
Could I add a little bit to that? Because I think what, just for some context, I think it's what we're talking about is some of the degree programs, you might have not the right credit or something, and people will be working in the field, and then there could be a way for them to be grandfathered in. is a way that some organizations have been able to do that. And if there's an opportunity to look into that and study it, and to see if that creates how many new pathways it opens.
Thank you, First Lady. And I think about that also in a couple of ways. One of the acceleration strategies that the HEC is involved with is credit for prior learning. So thinking about also on the education side, if there are strategies to for individuals to receive credit for time worked towards an advanced degree, and so in both the advancement opportunities in the career pathway, but also thinking about advancement opportunities within education.
Yeah, thank you. That's exactly what I was going after. I know there was a lot of people at Project Respond previously that would be able to like advance from their experience and their education combined.
Great.
Thanks, Liz. Ebony, do you have a new question or is your hand? Oh, okay, awesome. Wonderful. So we'll go to Sean, and then Van, and then there's a question in the chat from Clarissa that we'll go to after that.
Great, thank you. Of course, being in community college, especially interested in those numbers there. And certainly there's things we're doing, even just rebranding. We've used the umbrella term human services. People didn't know what that meant, so we've changed it to behavioral health and addictions counseling. And certainly the pilot with the state's doing with the QMHA pathways, where associates now can get licensed with an associate's as a bachelor. That's a big shift as well. That will be interesting to see how that impacts things. Curious, one of the things we've had to compete with, right, is this opportunity. We have this workforce shortage, and folks can do things like a Daystar, for example, right, and get hired without really much training, much face-to-face work at all, just an online program. So when we see that decline, is there any tracking in terms of looking at folks getting, say, CDC one licensure through non-college, just these more programs like a Daystar out there?
I don't believe that this report looks at the differences, but it's certainly something worth exploring in terms of the variety of degree and credential pathways, and looking at the supply and distribution of the workforce, not just through the demographic and geographic lenses, but also thinking about the distribution across the types of mental health providers and the types of services that they're
And the certification programs, right? Because I think those folks we see burn out more, they don't have the training, they don't have the support, they don't get the same thing. That's what we're up against, is folks saying, hey, I can get a job with just doing these quick online classes. But that's going to change the landscape pretty dramatically.
Yeah, thank you.
And Van, I think you were next.
Yeah, I just wanted to respond to Ebony's question. So I posted a link in the chat. It's our workforce analytics, and it is this particular page is just for mental health. We also have one for addiction, and it's real time. It's updated about every 6 hours, and it's only active people. So you can break down the demographics, and you can go county to county. You may even do region of the state. It doesn't look like it, but I have all of that data. So if anybody ever needs that data, I've got it all, age, race, exam scores, national exam scores. So, y'all just let me know and I'm happy to provide it.
Thank you, Van. Van is a data person, I've heard. Clarissa, to your question in the chat, did you want to read that?
Yeah, I just didn't want to interrupt everybody's good discussion. I was wondering, piggybacking on Jamie's question, wondering about the mental health providers, the definition, because I think I have a bit of a concern when you look at those rates per 1,000 residents. Here in Jackson County and Southern Oregon area, as part of the mental health team, when you look at prescribers, people who have prescriptive authority versus people who are LPC, LCSW, I think the picture becomes even more dismal, actually, because I would say, based on our panel sizes and the wait times for our services, I think that the numbers could be much affected and much worse actually when you just look at people who have prescriptive authority in psychiatry down here at least. And I have a concern that those, I'm not sure, is the definition all together or is it split out at all? That was my specifics.
It's a great question, Clarissa. I am looking at the report pages probably 18 to 21. There are a number of graphics about the rate of providers geographically and the demand for services. I am not readily seeing a definition of who is included in that, so we will follow up with you.
That would be great. Thank you so much. Because that was my suspicion, is that it looks a little different. It looks probably even worse.
All right, next to Rachel.
Thanks. I'm jumping in again because of what Liz said and the First Lady commented on. I think, and this is a higher education discussion, but I think that conversation around getting grandfathered in is one that the nursing community has had. And in Oregon, we made the decision that when you went on to become an APRN, Advanced Practice Registered Nurse, you have to get your doctorate now. And so all my students, while I'm a master's prepared, are getting their doctorate. And so I think that it happened along the way in nursing where, yes, you get to stay and you get to continue to do the work. Before there was the master's degree and then there was the CNS. So how many of the behavioral health professions have we done that with? How many have we said we need to have these higher degrees? And then that has created barriers. And if we're not going to change the decision to say this terminal degree is the best degree because we have the ability to practice at the top of our license, we want to, flex our muscle in all these different professions. But how do we make sure there's the entry points where you can work and get paid while you're doing that? And I think that is what got left out as we started to say, let's practice at the top of the license. So maybe that is something we can think about with higher education and all the behavioral health roles.
Thank you. Rick.
Yeah. So here's a question. I'm just, maybe I haven't read the report in detail enough, but so a little context. I'm a longtime community mental health director in Jefferson County. Jefferson County is the most racially diverse county in the state by a long shot. And so we try to get staff that reflect the community. So we're heavy Native American, heavy Latino, and trying to find a native Spanish speaker who can pass a graduate program and licensure test. Good luck, right? And we take extraordinary efforts to do that. And there's very few of them. And I guess the largest minority population in Oregon is the Latino population. It's doubled in size over the last 25 years. And I think we should have a very specific approach to recruiting and retaining that population, to serve that population. For instance, I had a program director for a long time. He had a master's degree from one of the most prestigious universities in Latin America, and that was never good enough for the licensing boards. So Portland State University, bless their hearts, was privileged over basically the Harvards of Latin America. And so it's like, WTF on that one. And so that really creates this barrier that we have in Oregon for we have all these built-in barriers for getting quality Latino services that really amount to institutional racism. I mean, no one's racist, but that's the result. So I would really, really like us to figure out a focus on that.
Thank you, Rick. Shira.
I would just kind of piggyback on what Rick was just discussing. This actually came up in the OHA legislative behavioral health workforce conversation that I also participated in last week. And we actually had an opportunity to review the transcripts of two folks who completed a 5-year bachelor's degree in Latin America, side-by-sided versions. And they are exponentially more rigorous than master's level programs in the States. And I'm curious, like, how is there any way to figure out how many folks, how many Latinx, Latina, Latin folks in Oregon have a degree from Latin America that could, if the licensing boards were to accept those degrees, like what would the impact be on our workforce? Because I definitely think that that's a really important strategy for us to consider.
Thanks, Shira. And Jennifer, I'm curious if the assessment had any connection to that question.
Thank you so much for the comments and the questions. Two things come to mind. First, around credit for prior learning, which has already been mentioned as an acceleration strategy, certainly part of the CPL assessment infrastructure, also considers degrees and credentials or education earned in other countries outside of the United States. So I think we'll have some work to consider there, in particular to this pathway, because I'm not sure we have fully explored that, and there is that connection with the licensing and credentialing overlay. So that's first and foremost, and we're fortunate. Shali Hodgson is the HEC's premier CPL individual leading a lot of that work. So we're fortunate to have her supporting our work here. The second thing that comes to mind is reciprocity agreements in general. The report does speak to that as a barrier. If I remember correctly, it is not unique to Oregon. But I do remember AHP identifying reciprocity agreements as an opportunity for Oregon to explore competitive advantage, because it's not unique to Oregon. Reciprocity agreements are challenging in states across the country. If that is something that the council is going to consider, AHP did identify that as a significant strategy, particularly when we're thinking about competing with other states for behavioral health workforce. So those are a couple of things to come to mind. I don't think it addressed this question directly, but those are a couple of intersects.
Thank you so much. Ebony.
I just, want to appreciate what Rick brought forward. And, I think that I think from my perspective, that we are struggling with issues, specific to structural, institutional, and systemic racism. We're also struggling with issues where we're seeing a disparity geographically. So there's, some intentionality that we have to, focus on from a geographic perspective too. But I just want to name that. And just the thought, not sure if there's anything that we can do, but my mind goes to, the psychometrics, is that what it's called? So thinking about the exam and the test, and there are implicit biases baked in. And so then I wonder, are there things that we can do to start to address some of the implicit bias in exam questions? And I know that the National Association of Social Work, I think at one point they were trying to explore some things, but just based on what Rick brought forward, my mind started going a little. So thank you.
Thank you so much. Julia.
Ebony, I think Ebony took some of those words out of my mouth. I was going to address, but one thing I do want to address is the fact of culturally specific counselors out there in this day and age, in this political climate. It is very hard for people of color to maintain, and especially with the mental health issues that are out there. For instance, there's very few culturally specific counts therapists out there for our young Black children. You can't, I mean, they're just impossible to find. And then, let alone the children, the adults, trying to get somebody that is culturally specific and that can identify with the issues that these people are bringing to the table in order to survive in today's climate. So, yeah, we really want to pinpoint that piece about like culture specific therapists, counselors, and addressing, because I would say culturally specific is very different from culturally aware or cultural, what's the other one? Cultural something. So
Responsive.
yeah, cultural responsive. It's very, because, you can traumatize a person of color all over again when you go to somebody that's culturally responsive. It can be very traumatizing. So
Thank you, Julia. Van.
Yeah, I just wanted to talk about some of the things that Rick and Ebony were talking about as far as the exams go. So one of the things that we recently did as far as the CADCs is we paid to have the CADC exam translated into Spanish. And in the exam, you can actually toggle back and forth between Spanish and English, which we found tends to have better outcomes. And for mental health, we've moved to a 3-question exam because all the studies that we've looked at is that a 3-question psychometric exam tends to be more inclusive. We're trying to get some of the other exam companies to also look at this data and change from a 4-question to a 3-question. But in Oregon, and this is long before I got here, and I've been at MACBO for probably 17 years. I think Eric Martin is the one that orchestrated this, but it's written into OAR 309019. It's called the portfolio review process, and I don't think it pertains to the licensing boards. I think it's just MACBO, but it allows us, if a person is unable to pass the exam, to make a comprehensive review of their entire portfolio and essentially waive their requirements. And that also can come into play when you have degrees from other countries, because they are, sometimes very hard to assess, and oftentimes they're much more applicable to the work than some of the U.S. degrees. So, I mean, maybe this portfolio process may be something to look into as far as licensing boards go. And then in terms of reciprocity, reciprocity is so hard to do from state to state. So I sit on the board of directors for the ICNRC, which is the company that writes the National Substance Use Disorder exam. And they have a reciprocal pact, and about half the states are in it. And it still creates problems going back and forth because we'll use the peers, for example. So in Oregon, you have to have an OHA approved peer course. In Washington, you have to have a Washington approved peer course. In California. So even if you have our CRM2, which is reciprocal in nature, you still may go to these states and they say, no, you got to have the Washington specific training. And it's a hard obstacle to overcome, but we're trying our hardest to create as inclusive of an approach as possible, because we do recognize there are some significant barriers. But I think the portfolio review is something to really look into as far as licensing goes, and I can post that OAR if anybody's interested in it.
Thank you, Van. And Rick, a question about the assessment, just noting that First Lady, I don't know if you wanted to jump in on discussion.
I just wanted to say that when MACBO went to the portfolio review, as opposed to needing to pass the test, that reduced the barrier. I mean, we just could not get native Spanish speakers to pass the test. even if they were really quite fluent. It was too much of a barrier, and the social work test is ridiculous in that way. So thank you.
Oh. Yeah. Well, let me just jump in because I am loving this discussion, which is exactly why you're here and why you're going to be the right people to do this. I do want to make sure, Jennifer, you're doing an incredible job. Just taking all of these questions, you're just doing an incredible job. And so I want to make sure that we use Jennifer's time well and that we get any other questions about the actual assessment. We can always email and that kind of stuff, but I want to see if there's any other questions related to that we can get out there today. And I don't want to put you on the spot, Jennifer. It's okay if you don't have this in front of you. But one of the things I didn't want to call out and just maybe ask you about, even if you don't have the exact number, is I just remember there in the report there was a dollar amount associated with turnover that I just remember I was like, oh my. And I just wondered if you don't even have that data, and if you just not speak to that a minute. Because I'm interested in that.
I don't have that right in front of me at my fingertips, but it was something that stood out amongst the key findings, and but I don't have the context. Maybe Clarissa was raising her hand. Maybe she knows.
I totally highlighted it. I just found it. It's 102,887,000 per, I think that's per provider. And then it's 1.2 billion in turnover costs spent per year just in Oregon system for turnover. I absolutely highlighted that.
I think we've got a couple more questions for Jennifer. Ebony, I'll turn it over to you, and then Summer.
The one question, the visual that had kind of that flow of the different disciplines. And I noticed it had certified recovery mentors, but I didn't see peer support specialists, and was just wondering, was that intentional, or are peer support specialists role? Because I know CRM and peer support specialists are two different. So just wanted to understand a little bit the difference between that, or why they weren't visualized.
Thank you, Ebony. We will make sure that you all have the link to the full career pathway map. Oh, thank you, Sarah Foster. Just posted it in the chat. It's about 7 pages. So that slide that I showed you was just a snapshot from the full career pathway map. And I encourage folks to take a look at that comprehensively.
Thank you. Summer.
Yeah, I was just wondering, and I might have missed it when I read through this. Is there any data available on how many of us providers are actually seeing clients full time, versus how many are now? And there's when you have a shortage, and all the positions for management, supervision, everything require licenses and advanced degrees. It creates a really short career. If people very quickly move up out of providing full-time clinical practice, and that's it. That data I think would be really interesting, because I think it's much more grim, like Clarissa was saying earlier regarding the prescribers being in the mix. If you factor in the number of us that actually don't see clients, it's a lot. And when the CCOs really came on board and started hiring massive quantities of people a little more than 10 years ago at this point, I think. And I'm just wondering how many providers have been, all these positions that require licenses that actually don't need licenses. And the pay disparity between these two things. And if there's some low hanging fruit that could be addressed in that, area. So those were just the thoughts, and whether there's data there and looking at, the pay differences and what really does require a degree versus, it's just what we've always done. So that's how we do it. Thanks.
I just want to jump in. Thank you so much for that, Summer. I do not believe that this report dives into sort of the provider capacity. So in that supply and demand context that we talked about around demand for services and looking at the behavioral health workforce writ large, I'm not sure that it distinguished between professionals who were seeing clients versus not seeing clients, and I'm not sure if there's a standard differential for sort of client capacity. So those would be some things worth looking into when we're thinking about the supply and distribution of the behavioral health workforce across the state.
Thank you. Rachel.
Yeah, so just I don't know about all the other clinicians, license types, but we do know in nursing that we are trying to say we can't really say a workforce shortage when we have more licensees than we've ever had. We have more NPs than we've ever had. So it is that summer. I don't know what the numbers are, and I don't know if it's others, but it's that we're not working full time and we're not working in the spaces that we used to. And why is that? And I think it's that conversation that we're having right now.
First Lady. You are muted.
Everybody's got to do that once per these things, right? Thank you for taking that. That was my other question, Jennifer. I feel like it might have been in there or not. I can't recall. But is it looking at it based on full time? I think it said in the appendix, but I don't quite recall if we're talking about full-time workers, part-time workers, or if we don't. That wasn't data we had.
I don't believe it distinguishes between full-time, part-time.
Okay, I know that has been a topic that has come up.
Mm-hmm.
Okay, I can do last call for questions before turning it back over to First Lady. Any other questions for Jennifer? Okay, if folks think of additional questions, you can, I'll put my email in the chat. Feel free to email them. And then I know Jennifer's working off of a list so we can provide responses and then send that as a follow-up to the meeting. So folks have responses to all the questions that you asked now and then potentially after. First Lady, I'll turn it back over to you.
Okay. Again, Jennifer, thank you so much. That's just incredible. So when I said the talent assessment was thrilling, I think it's, what all of these questions, I think what we're seeing, right, is that we are really identifying the core issues, and there's a lot to say about it, and that makes me really excited because we have the model to follow. So today the goal was to bring everybody together, go over the talent assessment, really ground people in that, and then want to give folks our next meeting is June 12th. It will be from 2 to 4. You should have a calendar invitation. Reach out to Chad if you haven't received it, and he'll make sure you have everything you need. Our goal is to get materials 48 hours in advance of the next meeting, including the agendas, and they'll also be posted on the website. We have a website, 48 hours in advance. And then goal of our next meeting is to really get into this discussion of subcommittees. As we talked about, our ability to do this all as one large group is that, this is our ability to get grounded in the work, but obviously there are different topics that need to get broken down, and then we really need to get into it in terms of thinking through different ideas, different solutions. And so that will be the kind of the priority of the next meeting, is to really think through how we're going to break this down. We're ending early. I'm sorry we blew through our break. The questions were so good. We sort of felt like that was the right thing to do. We can, please reach out afterwards and let me know. I know that you are all working and doing important things, and so I wanted to give you time to kind of check your email, all of that. And I also know that time is short, and being able to push through it sometimes is better. So we can talk about that later and just see what people will work best for them. But ending early, I think, is not the worst. Again, I just thank you so much. This has been just such an important discussion. I think we've been able to identify the work ahead, and I am just so grateful for you. So we will see you all in June.